Vale, check, check.
Kale.
इसको नीचे पीछे लगा दे, कहाँ लगाएगा देख ले, अंदर कहाँ रखेगा, अंदर यहाँ पीछे से रख दे, पीछे लगा दे यहाँ से, हाँ हाँ इसमें रख दो. You are getting my voice? Not much loud. Okay. So when you talk about the incisions, you all know what is approach, what is root. Root you go through the bone. Approaches you take through the soft tissue. So if you talk about lateral skull base, when you do a tympanoplasty or myringoplasty or mastoid, you can go by maybe the endoral route, or you can go by post-oral route, okay? Even transcanal you can do certain cases. A few people they take the fascia from other side and take the cartilage from the tragus, and then they can go transcanal, elevate the flap and do the tympanoplasty or osteoplasty, or even you can raise the whole flap 360 degree, put it anteriorly, start drilling transcanal, and people have done even transcanal mastoids, okay? So it's up to your skill, your preference. The outcome should be good. The result should be good to the patient. A small scar hardly matters. It hides behind the pinna, we know that. So if you talk about tympanomastoid, when post-oral approach you are taking, you know the William Wildes incision we take first. And what is that? Basically, William Wildes is, it should be from the post-auricular groove. This is the groove, you know, the gauze. So this is the groove. So from the post-oral groove, it should be 5 mm in the center, around 2 mm over here, and 2 mm at the inferior fixation of the pinna to the skull. So this is how you make an incision there. But when you talk about skull base, when you are going for maybe infratemporal fossa approaches for glomus, glomus is a misnomer, it is a paraganglioma. So or maybe the malignancies, whatever approach you are going, your incision should be one, the way it have exposure of the temporalis, superior temporal line, till the neck, at least till the level of the hyoid bone, so that you can explore the great. And if it is malignancy, you can take a lymph node sampling there from the level 2. Got it? Or even if lymph node is present, you can extend that till the midline, and you can drop a curvilinear from here. You take it this, and you drop a curvilinear here, so that you can open the level 5, level 3, level 4, and all, so that you can complete the neck dissection along with the malignancy. So if skull base you're talking about, like if you talk about Mario Sana and the Gruppo Autologico, their incision of preference is like this, a rectangle. They make a rectangle out of it, like this. You are getting this? But what I prefer, because when you make this rectangle, you do have only a small strip here, which is having some blood supply there. And over here, if you are so close, this vascular strip is very narrow, because anteriorly you will do a cul-de-sac, so your blood supply will not be coming through this far distance. And always note down that whenever you talk about a flap or a vascularized flap or a supply, if it is lengthier, your vascularity compromises to the tip of the flap. So you have to be very close. It should not be more than 3 times to the width of the flap. Got it? The length of any flap should not be more than 3 times to the width of the flap. So what I prefer is a big C-shaped incision like this, which should go in the neck. Okay. So this we'll take later, we'll cut. So this is mastoid tip, I can feel. This is mandible, the angle of mandible. This is mastoid tip. We'll take this incision from here, 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 here. Okay, like this. So then you make other flaps. Now, get me the knife. From here, I'll start like this. Okay, forceps. And then you raise a flap in between the muscle and the skin flap. The skin flap should not be very thin, around 3 mm. This is not a good thing. Big one, do you have? No forceps. You can elevate, you can hold it and then elevate. Or give me a scissors, I'll do that. When you are doing a cochlear implantation and you are raising a flap, what I prefer in cochlear implantation, many people have suggested many flaps. A few people, they have suggested a hockey stick flap like this. A few people, they go by the C flap like this, C incision like this. What I used to do was a flap like tip, 1 millimeter above. I used to start, it used to come like this and come like this. Fixation of the pinna is there. But nowadays, I've stopped this curvilinear S. I've started doing only a C-shaped post-oral incision, so that any of my incision should not coincide with the incision on the skin. Incision in the periosteum should not coincide with that. So you double press it, basically. Okay? So I'll do with scissors, because we don't have a bigger forceps. The skin flap, when you raise, it should not be as thin as it gets necrose. The muscle should be left behind. And it should not be as thick that does not give any electromagnetic interface between the processor and the receiver stimulator. Got my point? This is your muscular flap. I am leaving behind. Big, that thing we are not having that bigger one, forceps. It's okay. So when you talk about this thing, knife, the muscular periostal flap, many people do have preferences. Like, how many flaps do you know? You know the PAWAN flap, which is an anteriorly based flap, musculo-periostal flap. You know the posteriorly based flap that is known as the Portman's flap. Then you do have the inferiorly based flap, which most of the times I prefer. I follow the principles of Dr. K.P. Morvani, sir. That inferiorly based flap, how does it help? Because it is well vascularized with the occipital artery. Got it? And you can have this much big flap, and you can obliterate the mastoid with that flap, inferiorly based. But in cochlear implantation, I've stopped erasing a PAWAN flap. I now take the superiorly based flap. I'll show you how. How does it help? It's okay, it's okay. Yeah. We don't have that. Postauricular muscles. This is the plane. You can make out the fibrous plane there. The anatomy is so beautiful that you get the plane yourself. If you don't violate the planes in the dissection, in your surgery, you are not going to land up in the complications, believe me. These are cutaneous insertion of sternocleido-cutaneo-occipito-mastoid muscle. Yeah, okay, is it okay? Yeah. So it is not the sternocleidomastoid. It is sternocleidocutaneo-occipitomastoid muscle. It arises from two heads, from the sternum and the clavicle, and it inserts in the mastoid, occiput, as well as in the skin. These fibers, they are going in the skin, cutaneo-mastoid. Got it? So this is mastoid tip I have explored. I'll cut it some more. And there you go. Okay, and there you go. So if you talk about flaps, can you make out the vessels? Look at them. Which vessels are these? Posterior branch of superficial temporal. So when you talk about different flaps which you can use in mastoid, in skull base to obliterate the cavity, as well as to interpose when you do a TM joint surgery. Correct? Between the zygomatic process, the mandibular facet, and the neck of mandible, because you remove the head of the mandible in TM joint surgery. Then you can elevate it from here. And what is that incision known as? This incision you take just close to the tragus, go like this, like this. That is known as alkyd Bramley's incision. That is the most preferred incision for TM joint surgery. You make an incision there, go skin deep, directly go to the bone there, inside the bone on the mandible, so that you don't injure any facial branch. Then retract, your branches go anteriorly. Then go up to the temporalis muscle and raise the flap, do your temporal point joint job, and then this muscle or the fascia, based on the entry branch of the superficial temporal, you can raise and interpose it between the articular surface, so that you don't get reunion again. And believe me, that is the best interposing material. People have tried even rib cartilage, have tried bone, chips and all, not worked. Best worked is temporalis fascia along with the part of the muscle there. It stays back there. I have done many surgeries in the past. We are going to have it one next week. We are going to have. So now, this we have raised. If you are talking about, if you are dealing with a malignancy, here you have to cut the external caustic canal and do a cul-de-sac closure. Or maybe even subtotal petrosectomy, or maybe even benign tumors like paragangliomas you're talking about. You do a cul-de-sac because you are obliterating the mastoid and the whole cavity there. So in that case, raise it further. Now, if you talk about cochlear implantation, this is your inferior temporal line. Can you make out these vessels? This is your mastoid tip. So you incise it right from here, 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 and go like this, and raise it. How does it help? It helps the way your skin is coming here, here is your incision, here, and this incision is close to the canal. So which is not coming under the skin incision. And even if you are going up to here, the whole thing, the whole implant and the electrode array, as well as your, maybe the cortical mastoidectomy, maybe the well in the Varia technique, would be covered by it. Not at all exposed, because this whole thing is there. I'll show you how. This is the way you raise, you go till the mastoid. This is mastoid. Come here, and then you come here. Here you have to be very cautious because some structure is there. What structure is there? A mastoid emissory vein. Okay? And then you come up there, like this. Get me elevator, mucoperiostem elevator. Any question, please ask. Elevator, yeah. दूसरा elevator नहीं वो वाला नहीं है फिर वो yes, I'll take the knife. Look, such a big flap. You can even use for mastoid obliteration. Superiorly based, inferiorly based. Can you make out something? Some structure coming there? What is this? The emissary vein. I am cutting. Got it? The emissary vein. Yeah. In the lab surgery, you can bipolarize. You can use the bone wax to fill the bony defect there. Oh. The big one, you don't have Ferrabo. It's okay, it's okay. We'll do with this. Got it? So this is sort of a superiorly based flap I'm elevating there. Give me the knife. Yeah. Okay, so implant goes somewhere here, and it is well covered with it. Now, we'll start doing. I was talking about cul-de-sac closure. When you come at this stage, you cut, you elevate it, depending on the involvement of the external acoustic canal, up to which level it is involved. Leave 1 centimeter margin with that, and cut the canal. Cut the canal, take it anteriorly. And take it anteriorly. You can use sutures. Now, when you do cul-de-sac, the first step is to do the cul-de-sac before doing anything inside. So what you do in cul-de-sac, this is your external acoustic canal, the lateral margin. You hold it with the forceps. Yeah, take it. And remove the cartilage around the skin of the canal. Along the almost up to tragus. Like this, you have taken out. Got it? And then this canal skin is taken out like this. It is pushed outside. Like this. And you suture it. Okay? You suture this, blind sac it. Then the second layer should be taken with the soft tissue. A blind sac closure should be very good. If it remains open, it will lead to infections later on, and the condition would be hazardous to the patient. You can't deal with that condition, very difficult to deal. Got it? So take it anteriorly, okay? You make a suture, fix a suture there. Now we'll start with the temporal bone, okay? Yeah. ले लो, कहीं से भी ले लो. You have to take it a bit close to me. So you can very well appreciate the mastoid vein. You have to always be watchful to this mastoid vein. It bleeds a lot. So you have to keep it in mind when you are raising a flap there, it will come. Can you make out this vein? Okay? In lateral sinus thrombophlebitis or sigmoid sinus thrombophlebitis, what happens? This vein gets blocked and there would be edema there in the postoral area. Which sign is that? Yes. So this is the vein responsible for that because it is connected to the sigmoid sinus inside. Okay? Over here also I'll cut some more. So that. Yeah. No. Rather, the cartilage should be removed from around the skin. And third, people say that you can suture the cartilage. But is it possible to suture the cartilage? And when you leave the cartilage along the skin, sometimes perichondritis happens. So it is better to remove the cartilage all around and then make a suture and push this skin sac outside. And then close the soft tissue under it. So that would be sufficient. And then the third layer would be your flaps itself. Your flap you would be using to cover the things. Got it? So now we'll start drilling. Get me the drill. Yeah. Now the principles of mastoid, the most important landmark is what? Glass panel. First thing is your spine of Henle. There is a criteria known as Anson's and Donaldson's criteria, in which if you find it very prominent, the spine of Henle, if it is very prominent, you have to expect prominence of ridges on the promontory as well. Prominence of tympanomastoid suture as well. Got it? They would be there. It would be rough. So that was Anson's and Donaldson's criteria. It has been published by Toss in his textbook. So the first landmark you see is spine of Henle. Now, what is McEwen's triangle? So this is inferior temporal line. The superior temporal line should be like this, up there, inferior temporal line. You start, you take a line, an imaginary line, along the posterior canal wall. Got it? Second comes along the zygoma, inferior temporal line like this, and the third line which is connecting them like this. So this makes your McEwen's triangle. Or even if you can't make out something, always try to remove the fascia from here, the soft tissue and the periosteum. And you will see some hair cells there. That is Cribrosa mastodica. Got it? Some hair cells which are opening there, they would be there. And you start drilling there. Got it? Yeah. क्या लगा दिया? Yeah. Conical drill, okay. Okay. ये इसको और करूँ? For the ease of dissection, I am cutting this muscle. Got it? A bit more. Just for the ease of dissection. Don't do it in the live patient. Just for the ease of dissection and showing you. This temporalis muscle fascia network and subcutaneous network over here. It is, I'll focus it, don't worry. This network has got three flaps for you for reconstruction. You go just under the skin and you do have vessels supplying this subcutaneous tissue. That makes a big flap. The second flap is your temporalis fascia flap, which is supplied by different set of vessels, superficial temporal vessels. Then you have this temporalis muscle flap, which is further supplied by a different set of branches given from the superficial temporal artery. So God has given you 3 layers Saucerize your cavity. Don't do a burr holing there like this. Saucerize your cavity from all around. That is required. For what that is required? 2, 3 things. One, you will be getting more space for your drill and instruments to work inside the depth of the cavity. 2, if you don't saucerize it, and when you have done the mastoid job, unsaucerized cavity won't let the soft tissue grow in the cavity. They would be like this, sharp edge. If you saucerize, the soft tissue will herniate in and fill the cavity. The squamous epithelium will grow. And you know that grows by 1 or 2 mm per day. It takes months to cover the whole cavity. So better remove all the nooks, all the ridges, and make it smooth so that your epithelium fastly grows in the cavity there. I'm exposing a bit of the dura there. You can see the change in color there. And then you go along the canal, you open. Look what I'm doing, rounding up my edges. Rounding up my edges like this. And that should always be done. And the entry canal wall should be made as thin as possible, papery thin. How does it help? Removal of the disease, first, getting more space, second. Third, suppose cholecystoma recurs, you have done an intact canal. A cholecystoma recurs, if it is very thick bone there in your posterior canal wall, the cholecystoma will find some other places to grow. It will go intradurally, sinodural angle, labyrinthine fistula, facial nerve canal erosion. But if your posterior canal wall is very thin, at first it will break it and come in the canal. And easy for you to deal with without complications. Got an idea? So it should be very thin. Okay? This perisinus air cells would come, that should be well explored. Presinus, postsinus, perisinus air cells. If you are dealing with mastoidectomy, the mastoid, you should know what are the mastoid air cell tracts. Wherever they go, you have to be able to explore. You have to make an attempt to explore the air cells. You can't it is not heavenly possible to remove each and every air cell from the temporal bone. Of course, even if you do a subtotal petrosectomy, what is that? Exentration of each and every air cell system with canal down. Basically, radical mastoidectomy with removal of each air cell tract with cul-de-sac closure and closure of the Incision tube. That is subtotal petrosectomy you do. Got it? Okay. So you have changed? No. वो बढ़िया please. These are air cells there at the tip of the mastoid. Can you make out? But change करूँ? Not good. मज़ा नहीं आ रहा इसमें मुझे करने में. Let's change. So try to make it, try to saucerize it. You can see the dura there. You will see the sinus here in a bit. This is mastoid tip area. I'm exploring the cells. A well aerated mastoid looks like. Very cellular, very aerated, well pneumatized mastoid. This patient has got, this body has got. Canal wall thinning. Don't worry, your facial does not come like this. Okay? You can keep on because canal is slanting like this. If you do like this, no issues. You won't come in the external caustic canal. It is slanting like this, so you can go like this. So which structure is appearing there now? Again, rounding them up. इन बच्चों के लिए पिस्टन मंगाने थे, पिस्टन भी मंगाने हैं. Going towards mastoid tip. What is the landmark there at the mastoid tip? What landmark you are trying to see? Is digastric ridge. You are not certain where the antrum is. In spite of drilling bone here and there, go along this tegmen. Go along the tegmen. See the dura there. And if you have seen the dura, go along the dura. Go only along the dura, and you will find the antrum there. You are going along the dura. Can you make out? So I am going along the dura, and you will find this is tegmen, no? You are going along the tegmen, and you give me a smaller bar. Can you make out the dura there? Sinus there. So this is sinodural angle coming there. So when you are in a fix, go along the dura. Small. Funny. When you are going along, more air cells coming there. Drilling all around. And you find something there. Got it? No. Okay, I'll orient you guys again with an instrument. So you see the spine of Henry there? Don't worry, your antrum has not come yet. The antrum is around 1.2 deep the cortical surface. Spine of Henry, this was the level. We are here. We could not find the antrum there. It was probably the corners, intact corner septum there. Got it? So we went along the dura, we went inside, and now you see some ASL there. Got it? Now if you remove this bone, you are in the antrum, the largest air cell there in the mastoid system. So don't panic if you don't find antrum in the first go. Follow the tagman. Got it? Can you make out now? Thinning it further, thinning it further, thinning it further. Here you are safe, don't worry. Unless you see the lateral semicircular canal, your facial is not going to come. Your facial is anteromedial to the lateral semicircular canal. It is deeper than the lateral canal. So your facial does not come like this. So you don't have to worry unless you reach till the level of the lateral semicircular canal. I'll show you that. Oh, I welcome Rekha ma'am. We do have with us Dr. Rekha Ashwardhan ma'am. She is senior professor. Unit head, she is ex-HOD, ENT, my teacher. Learned a lot from Rekha ma'am. The most calm, cool, contented faculty we do have there in our department. And she is always ready for anything good you want to do for the department, for the students, for the patients. She will never say no. Some more ASLs I am exploring. And you have to make the canal straight so that head-on vision should be there. When you are doing a posterior for implant, if you keep on like this, you will be going like this in the posterior anatomy. And what happens with the shaft of the burr, you will be injuring the facial nerve. So you want a head-on approach like this. To make head-on approach, you have to thin it further, this bone further. Further, 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 further. I'll show you the atic shortly. Explore the atic area some more there. I am going towards the root of the zygoma to expose my adductus and posterior atic. Got it? And this is how you should do when you are doing intact canal. Inside out drilling, so that you don't jump, your burr doesn't jump and go on the lateral canal as well as the facial nerve entirely. Getting my point? This is how you go inside, out, inside, out, inside, out. And you see the lateral canal there. Can you appreciate that? This is the lateral canal. Change of color is there. Can you appreciate that? I'll show you further. When you tilt your microscope and peep in the adductus like this, I will have to bend my back. What structure are you seeing there? You can see the short process of incus? Okay. So now you have reached there. Further drilling is required to make it some more thinner there, like this. And these air cells should go. Some more air cells. They are at sinodural angle. Can you make out? So this is your sinodural angle. Some more air cells, okay? Thin it further. Your facial nerve is medial to the lateral canal superiorly, but when it comes down the vertical part, it becomes more lateral. This is your presigmoid bone plate we are removing. Presigmoid cells we are taking care of. Got it? Can you make out the sigmoid sinus now? You leave parts of the bone, islands of the bone there. What are they known as? Bill's island. Why do you leave the Bill's island there? So that to protect the sigmoid sinus from your burn and instrumentation. You leave eggshell bone over the sigmoid. Bill's island with the name of William House. William House, people used to call him Will. And then they started calling him Bill. Not Will, Bill. So it became Bill. So you do have a Bill's island on the sigmoid. You do have a Bill's bar, which I'll show you later. It's okay. Going further down there, I want to see the digastric ridge there. Because that is my another landmark for facial orientation. If facial nerve and carotid was not there in temporal bone, was it so interesting surgery? Or difficult surgery? No, not at all. So what you have to take care of is facial and carotid there. If you have taken care of both of them, these ladies there, always take good care of ladies, you know. All 7 nerves are like your lady at home. For males I'm talking about. Adore them. Handle them with care, softly. Got it? Don't be rash to them. And this is what you have to do with internal carotid artery and all the nerves which have come in the head and neck region.
Excuse me, sir.
Yeah.
Sir, in the lower part of the vertical segment,
Yeah.
how much laterally can it come, the facial?
Yeah, it comes till the digastric ridge. It will never go lateral to the digastric ridge. You know, if you talk about anomalies of facial nerve, there is no anomaly which says the facial nerve was found lateral. No. It could be anterior, it could be posterior, it could be bifurcated, trifurcated, fourfurcated, fivefurcated, going even through the stapes crura. It will never come lateral to the lateral canal superiorly, lateral to the digastric ridge inferiorly, except in infants up to 1 year, where your mastoid tip is not there. So the facial is in local or original position. But because the mastoid tip is not there, you make an incision and you are on facial in infants. Got it? So that is a change. Otherwise, facial never comes laterally. It is no anomaly have been ever reported coming lateral to the lateral canal. Got it? Okay. So we go further. I want this very thin so that my head-on view should be good. Don't worry, here is nothing. Nothing is there. You are lateral to the canal, so nothing is there. Some more air cells. Some more air cells which are connecting with the retrofacial cells down there. Can you make out? These must be the retrofacial cells. If you go further down, down, like this. Remove the lateral parts also. Don't ever work in a hidden area. the tip of the instrument should always be visible to you. Burr, tip of instrument should always, never do anything blindly in a closed space. Okay? Okay, good job. So, Dhirendra is helping me out, a big burr, so that I knock it off. What I'm doing, please don't do it like this in surgery. This burr should not slip from here and there. Just for the sake of time, I'm being a bit fast here. Okay? You are not supposed to do that. Yeah, I'm delineating the sigmoid there. And what do you see? What is this? Digastric comes there. Got it? So this is digastric. Can you make out? Should I be like this? Can you make out the digastric there now? Visible? So this is digastric ridge comes there. You have to be lateral to that now.
Sir?
Yeah.
Sir, in sigmoid sinus anomalies, when there is anterior lying sigmoid sinus, how
Yeah.
to go about that?
How to go about that? So even if it is an anterior lying sigmoid sinus, you should get CT scan in all cases. So you can make out an anterior lying sigmoid sinus. In that case, if it is a, whether in inactive or active squamous disease, come inside out. In that case, you should come inside out. But if you talk about cochlear implantation, and it is anteriorly placed sigmoid, low dura there, you don't get much space for cortical mastoidectomy and posterior hypnotomy. In that case, I'll prefer varia. As such, I do both the techniques, and we teach both the techniques to our residents. So even if you are a proponent of a posterior hypnotomy technique, what you can do is, because your sigmoid is anteriorly placed, dura is low, you do a mini cortical mastoidectomy, and you make 2 cuts at the canal, posterior canal here and here, and push this canal anteriorly. Got it? So you can push the whole canal anteriorly. You will find some space to make the posterior hypnotomy and put in the implant there. But if you are not adamant about your posterior hypnotomy technique, in that case where low dura, very contracted mastoid is there, just do a varia technique. That is very easy, because that is a transcanal technique sort of thing. It goes along the posterior canal wall, and you make a tunnel and you are done. In case of mastoid surgery, if it is contracted, come inside out. That is the best way of doing it. So now, some more. So you can see the incus there. Which harbors this short process? Fossa incutis. And what other thing is there? The posterior incutal ligament. So the fossa incutis harbors 2 things, the short process as well as the posterior incutal ligament. And you can very well make out there. I'll show you tilting it some more. Got it? You can very well see that, I suppose. If I move, you will see. Okay? So this is fossa incutis. Now, if you want to do, this I'll do further. At first, I'll show you the posterior hypnotomy now. Making further vertical, no slant, vertical posterior canal wall. And you start drilling here. In the line of the short process of incus, you start drilling a small burr. So you take it and you start drilling here. Wherever possible, try to use the maximum permissible size of the burr, because thin burrs, they penetrate here and there. You don't have much control on thin burrs. But if it is a thick burr, it is a larger burr, it will not go, not penetrate. Getting it? So I am drilling almost vertical along the line of the short process of incus there, like this. Further, if you are not comfortable, you can use a diamond there, but here I prefer using a cutting burr, because my facial is not that superficial. It is deep. It is deep to this canal. So no worries. Leave a ledge of the bone there, just inferior to the short process. Okay? That incutal ledge, or I call it incutal bridge. So this around 2 mm, 3 mm bone, a ledge of the bone, leave it so that incus is not disturbed there. You are seeing the way I am doing it? Upside down like this. A tympanic isthmus, and from the space which is around the suprapyramidal and infrapyramidal spaces. Got it? Wash, wash, wash. I'll take a smaller burr there now, or a diamond. Diamond. Which one? Here. This one is a diamond, or इससे बड़ी diamond नहीं है? छोटी छोटी. One more ASL. Look, your facial. Facial. Can you make out this structure there? I'll make it 0.6. And then can you make out the facial there? Is it visible to you? Yeah. Yes, that red one. Got it? So this is vertical facial coming in view. And here, now give me a smaller bar. This is diamond. Oh, great. We found a diamond there. You go further, and now anterior to facial, keeping almost vertical, like this. What I'll do is, I'll take a smaller section now. So, to push it back, okay. Drill this bone anterior to the facial. Anterior, inferior. Can one of our SR or resident keep taking pictures along, please, with all the delegates, all the faculties, honorable faculties we do have in the department. Our knowledgeable fellow, Dr. Shashank, is sitting behind. He is yet to utter, I know. He will come up with something very important tip to you guys. Now, what do you see? You see the round window in the depth. Can you make out? So you have to be able to see the round window. I'll show you that with the magnified view. Can you make out the round window there? I'll show you by sucking this fluid from there. Can you make out the round window? Can you make out the pyramid there? This should be your exposure in posterior hypnotomy. Give me an instrument, okay? So this is your pyramid. Can you make out this pyramid? And this is your stapedius tendon. Look, I'm moving. This is your stapes, and this is your round window, okay? So what I have to do now, making a cochleostomy, it's up to your choice. If you want a separate cochleostomy or you want to go to the round window, what my preference is, I go along the round window. Nature's pathway. Nature has already given you a window from where you can put in your implant. The only thing is you have to drill the lip, anterior superior, anterior inferior lip of the round window to get the full exposure of the round window membrane. And your round window is like this. Look, this is like the lip you have. But you know, the membrane is not like this. The membrane is like this. So you have to drill this lip and you will get the membrane. And once you get the membrane, over here, posterior inferiorly along the membrane, you do have hook region, crista. That crista should be broken or drilled so that your implant does not collide with the crista and does not get through the basilar membrane. Got it? You want the implant to go in the scala tympani. So it should go like this because membrane is this and your lip is this. So if you drill this lip, your membrane would be visible. I'll show you how. And if you want to make a separate cochleostomy, there are two places you can make it. You see the round window lip, draw a horizontal line in the center of the anterior part. You can go along this, just enter to it, or more preferred would be anterior inferior to it. Make a cochleostomy, you are in the cochlear duct. Got it? In the scala tympani. I'll show you both the things. Yes. So when you are putting it is right here. You are coming, your implant is coming like this. If you keep on doing like this, does not work. It will perforate. So that would be transscalar migration of the implant. Your implant will perforate the basilar membrane. It will come either in the media or it will go to the vestibuli. And your sole purpose is gone. Although you will get an RT, but on a higher voltage. But your hearing would not be good. You want the implant to go all along the medial wall. Got it? No transscalar migration should be there. So at first I'll show you the round window lip drilling. No, get me this 1 mm. And the second thing, if you don't find it, you find it difficult to insert the implant through the round window, you make it extended round window. Anterior inferiorly, you inferior part of the sinus tympani, this scala tympani part, the outer part, a bit, you have removed the hook, and this is extended round window technique. You will see the whole thing. Dr. Satish Jain is a proponent, big proponent of extended, but I am a proponent of a round window insertion. Just like Skarzinski, who runs World Institute of Hearing there at Poland, Warsaw. He does around 10-12 implants a day. He puts an implant through the posterior tympanoid through the round window itself. Every day he does 12. He has got 18 MRI machines there to study about the hearing there in different areas and all those things, experimental things they are doing there. I was fortunate enough to be invited in the Politzer Society meeting as a keynote speaker and got a chance to see their work for 5 days. Yeah, a smaller one और पतली है. एक और था ना दूसरा किट, खोल लो ना उसको. ला दे, ये तो दे. वो डब्बा. नहीं अपने पास काफी सारी बोर हो गई ना. नहीं वो था ना ये सेट. इसमें है पतली दे. 1 mm की होगी. I told them to get us 1 mm. हाँ ये मिल गई. Yes. हाँ वही दे दे. हाँ ये रख दे इसके पास. Irrigation. You guys are seeing this? This is lip. I am going to the lip, drilling a bit very carefully. Please put in some saline. Can you make? Once I have done this, can you make out something? You see the membrane there? You see the membrane easily? Just drilling the lip a bit, you see the membrane. What do I need to do is just take a hook and open it like this. But not now. Once your implant here come, look, the perilymph is coming from inside. Do not open the round window unless you have fixed the implant in the well. Just do this job, pack it with a few antibiotic soaked gel foam pieces there, put the implant in the well, you are all done to insert the implant, then make a nick and insert the implant. So that is atraumatic technique, minimal invasive technique, okay? And it gives you a good Look, can you make out the hook? The anterior inferior part, there is a ridge which is coming inside. I'll make it more vertical and show you. Okay, now. Seen? So, you, whatever, क्या है hard क्या है तुम्हारे पास? This. मैंने मंगवाया तुमने कहा था खरीद के लाओ. This I am breaking a bit. खरीद के लाओ. बाद में दिखा दूंगा. खरीद के लाओ. Got it? Such a big cochleostomy through the natural orifice you are getting. Why you want to extend it any further? Got it? Now it is not going like this. It is going like this. Your duct. Got it? Now I'll make a cochleostomy. I'll show you how to make a cochleostomy. So this was your round window lip, and I told you antero-inferior, a bit antero-inferior. Small burr, वो वाली पतली. नहीं, एकदम पतली लाया था ना? Yeah. So you take a 0.7 or 1 mm burr. Got it? And go here, and don't go like this. Your facial is being pressed. Go like this and make an opening there. Just see. Don't go in one go. Drill a bit, drill, and then suck, and then see. Then go in. Go in. What you find there? You have made a hole there. Can you make out? Can you make out? I'll show you by the pick now. This is your round window, and that is your cochleostomy you have made. Don't manipulate cochleostomy like this, just a bit suction job. Look, that is a separate cochleostomy you have made. Got it? So, any suture material you do have? Okay, you guys do it, implant, while you're dissect. I'll show you. So, we have done a posterior remote, we have done a cochleostomy, it is all done. Now, what we have to do is labyrinthine block, exploration of the labyrinthine block, okay, in your temporal bone. We'll do that. Now, make it more vertically oriented, lower down the magnification to 4 times, go a bit medial, and now try exploring the labyrinthine block from all around. Give me a medium-sized burr. Yes, this is good. सारी बर गिन लेना, सब बच्चों को देना है. 5. So this is your labyrinthine block. Can you make out this little? I am going infralabyrinthine here. Give me a big section. हाँ बढ़ा दे दो. कितना टाइम हो गया? For all these air cells around the labyrinth, in that sinusoidal angle there. कोई बात नहीं. Come to the posterior fossa dura. Can you make out these deep structures just like lateral canal? This is your lateral canal, something is coming like this. This is your posterior canal. Posterior fossa dura is exposed. I am going all along the labyrinthine block. Can you make out? Up there, superiorly, and you see something is coming in view. That is your superior canal. Can you make out? Again, this ivory bone is coming in view. These are the air cells, perilabyrinthine, retrolabyrinthine air cells. And from here you can do even retrolabyrinthine vestibular nerve section. You don't have always to go through the retrosigmoid approach. You see the labyrinth, elevate the dura here, go inside and you will see the external acoustic canal, internal acoustic canal. So, these are the infralabyrinthine cells. Can you make out? Retrofacial infralabyrinthine cells. And they are well connected with hypotympanic cells. From here, what you can do in cases of paragangliomas, the glomus, if it is going in the mastoid through the hypotympanum to the mastoid, what you do is you make a bridge of the facial. You keep the facial intact, you go behind and deep to the facial, and you go anterior and inferior to the facial in hypotympanic cells and make a connection there, remove the tumor. So that is intact facial bridge technique you do for these paragangliomas. I have shown it in one of my cases to the previous batch of our residents. These are infralabyrinthine and retrofacial cells you are exploring. This whole what I have done has to be done by the temporal bone group batch. Okay? And you will do a canal wall down also then. But for skull base people, इसको open करो इसमें. For skull base dissection people, they should keep the canal intact because they want to do a lateral temporal bone resection for squamous cell carcinoma or any other malignancy which is there in the external canal. Okay. Pre-sigmoid I am going. I am getting space. What happens this sigmoid sinus inferiorly? It curves, make a bulb there in the hypotympanum. छोटा दे दो. हाँ, it is not going in there. This is what I am doing. I am going towards Petrous apex. Got it? What are the various approaches for Petrous apex? The superior approaches, the inferior approaches, or the transaortic, transcochlear, translabyrinthine approaches. Superior approaches, you know, a lot of Renedius, Eagleton's approaches are there. Inferior approaches, hypotympanic approaches, retrofacial, infralabyrinthine approaches. Okay, so these all things, they are taking you to the Petrous apex. How Petrous apex is oriented in this patient? This patient is lying like this. The Petrous apex is not like this. Petrous apex is going medially and anteriorly. Got it? So going medially and so all these air cells, they are taking you towards Petrous apex. All these air cells, they do have a track towards Petrous apex. Okay. So these are infralabyrinthine and retrofacial approaches. You drill the bones, the cells more, and you start seeing something coming there. I'll show you in a while. Can you see something? Look, I'm pressing it somehow. Can you say something? What is that? Jugular bulb. So your jugular bulb is coming in picture now. I have reached to the hypotympanum through the retrofacial cells. You guys are able to see there, no hang-ups? It is well visible to you guys? Okay. Any query, please ask me. And I am learning from you as well. If I am wrong somewhere, please correct me. And there are some, we guys are getting old. So there are some old thought process going on in our brains. Sometimes even the wrong thing we make our principle as such. So please correct me if I'm wrong somewhere. Especially Dev. Where is Dev? Dev, you are working with that guy, Cherian. And Sampath you have worked with a lot. So you must be knowing ins and outs of skull base. I didn't know why you, next time you are coming as a faculty. Okay, so he is as such, he knows ins and outs of lateral skull base. Cherian pushed him to come to me, huh? Cherian told you? Okay? So there you go. Now we'll confine ourselves to the temporal bone group. Can you make out the labyrinthine block now? I'll drill some bone there so that I can retract my sigmoid a bit. I want to retract the sigmoid to reach to the posterior fossa dura so that I can see what? Endolymphatic duct I can explore. Now, after doing this, if I tilt towards me, you start seeing something there, some whitish structure which is coming. What was the landmark? You draw a line along the lateral semicircular canal. What is that? Donaldson's line. and where the posterior canal cuts it, intersects it, posterior inferior to it would be your endolymphatic sac or the duct coming. And if you can make out, there is some white coming in view. Can you make out that white thing coming in view? That is your endolymphatic duct. And when you are doing an acoustic neuroma or any CP angle tumor, you have to cut it so that it lets the CSF out. And it lets you work at least 270 around the internal acoustic canal trough. Oh, sorry. Sorry, I'm taking a bit of more time, but don't worry. I'll give you enough time to dissect. Maybe today, maybe tomorrow also you can dissect. I'll get more microscopes for you. Don't worry. Okay? Learn good things. Okay. See if I press, give me elevator, freers. Freers नहीं है तो कुछ और दो elevator. Repositor है? Okay. Give me this. So if you press the dura of the posterior fossa, can you make out? Can you make out this? Can you make out this sac? I have opened it, look. Give me sickle knife. People used to put in some stands also initially when they use. And believe me, this is a very good surgery. There are a school of thoughts that for many years it doesn't work. It works well. It works well. Such an easy job for you, for all ENT surgeons. Do a cortical mastoidectomy, see the labyrinthine block, go posteriorly, elevate the dura a bit, depress, and you find the sac, make a nick to it, flap, open the flap, and job done. Can you make out? Look, I have opened it. Yeah. So I'm making, look. Here. I'm making a cut to it. If you see, it is going there. After elevating it is basically, dura is folding it. And now, you make a cut and you open it. Can you make out? Look, already coming. Okay? So I have made a cut. You can make flaps out of it. Look, like this. So, what is vestibular aqueduct? What is vestibular aqueduct? Is the bony covering of this endolymphatic sac itself. So if this endolymphatic sac is enlarged in cases of cochlear implantation, it makes a relative contraindication or a big difficulty for you during the implant because there are chances of getting a CSF gusher. Got it? Don't ever confuse between a perilimb gusher and a CSF gusher. A perilimb gusher comes from the scala tympani itself. If there is dehiscent carotid, dehiscent jugular bulb, dehiscent superior canal, Hirtle's fistula, congenital fistulas, they can cause brain pulsations to be indirectly transmitted to this perilymph, and there would be gusher, a bit. that is not CSF, don't worry about it. But if this is enlarged, because of this enlargement and that pressure going in the labyrinth, then it will propagate as CSF leak there, gusher there. So what forms this endolymphatic duct and sac? Ductus reunions and two ducts are there, the saccular duct and the ductus reunions, and it goes and connects directly down there to the labyrinth. So the whole pulsations are transmitted to the whole labyrinth. You open the lateral canal, there would be CSF gusher through the perilymph. You got it? So this we have seen now. Now for temporal bone group, if you further want to, you do have some time, you can delineate these lateral, the canals. Got it? I'll go lateral and now. How to delineate them? Start drilling. मुझे वो दो diamond. Moderate size की. इससे थोड़ी छोटी. हाँ. कोई. चल वही दे दे. ये. Okay. So I'll show you to do how to do the labyrinthectomy now. How to delineate your canals. Can you very well make out the canals? Section blocked. Give me a bigger section, a bit. This is your facial. If you want to do a transcanal facial decompression, you can go like this. Intercanal facial decompression. You go along, and go like this. Drill a bit of the posterior part also. You are seeing, huh? Zoom in? Okay. He wants to see the facial. Yeah, properly. I have to come out a bit. And I'll show you. And then, isko karo. Can you see that? Some more, huh? Your facial is there, okay? And it is going like this there. Funny. Sorry. It's okay. Can you make out the whole facial now? The vertical segment? Okay. So now we'll do the labyrinthectomy. So this is your canal. Pani. Come like this. Pani, वो blow obstruct कर देगा. Can you see the duct there? You see the posterior canal? Okay? There should be the ampulated end, there should be the non-ampulated end. which fuses with the non-ambulated end of the superior canal to make the crus commune. Okay? So this is your superior canal there. In depth. Try to see that. Can you make out a bit? Funny. Who's allow this man? Superior canal, got it? And it is crus commune should be somewhere here. So superior canal is more medially oriented as compared to your lateral canal and the posterior canal. Lateral canal is the lateralmost, the name itself. Then the level is the posterior canal. Then the level is the superior canal. If you don't put much water, this is gone. Look how deep is this. Can you make out the inner perichondrium there, periosteum there? Look, I'll show you. Here. Here. And this is your crus commune forming there. I'll show you furthermore. So when you do have a superior semicircular canal dehiscence syndrome, from where you approach it, at first you get a Poschel's view on MR to get the dehiscence there. And to approach the superior semicircular canal dehiscence, there are two approaches. Transmastoid underwater route, and the other route is middle fossa approach. You make a small window there, go along the dura, elevate the dura, and you reach the arcuate eminence. What is arcuate eminence? Is the bulge of the superior semicircular canal. There is the dehiscence, put in some soft tissue or fascia there, come back. Job done, without opening the mastoid. Or you can go, because you are more habitual to doing mastoidectomy, do a mastoidectomy, delineate the superior canal, and then go in. And underwater, you dissect the superior part of the dura. I'll show you how. On. छोड़ो छोड़ो कोई बात नहीं. हाँ इसको या ऑन कर लो ऑन.
Sir, while drilling in the supralabyrinthine area for excentrating the supralabyrinthine air cells, how can we prevent injury to the superior canal, sir?
Superior canal.
Yes, sir.
So superior canal is deeply placed. If you are at the level of the lateral canal, you will not ever injure the superior canal.
Okay.
That is one way. The second way, follow the dura.
Okay.
Follow the dura and remove the air cells and make some space there. Use a thinner burr, preferably diamond burr, and remove the disease, come out.
Okay, sir.
Don't try to explore unnecessary structures there when you are doing a mastoid.
Yes, sir.
But if you are doing a superior canal dehiscence, you have to go there, like this. This is your dura. Go along the dura. Reach to the height of the superior canal. There. Look. Look. I have reached, I can elevate the dura there. I have reached, this is arcuate eminence, intracranial part coming. Look, the superior canal there. So you reach there, put in some soft tissue, come back and cover it with some more soft tissue there. You are done. Now, superior some more. Pani, pani, pani. Can you make out the end? The ampullary end of superior canal there. This is the ampullary end. Okay? And this is the non-ampullary end there. Pani, 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 good salam. Okay, this one. And it makes the crust commune there. Got it? So this is all drilled. Can you make out this? And what is coming there? Now what is this white structure? This is Mike's dot. They call it Mike's dot. It is basically the subarcuate artery, which appears as a thin line on CT scan. Amreen is going to tell us tomorrow. A thin line, medial to lateral towards the canal, coming towards the superior canal is the subarcuate artery which is coming. And this is a very good landmark for the superior limit of your internal acoustic canal exploration. What is the inferior limit? Cochlear aqueduct. What is the superior limit? Subarcuate artery. Got it? This should be made clear. Base group, you should know that. Okay. So you want me to show you the canal down now? Canal down? Okay. So for canal down, I'll come a bit wide out. You save the flap. You save the flap because this flap is important. A few people, they jeopardize the flap in mastoid. Don't ever do it. It should be inferiorly fixed flap. You cut it from superiorly so that this flap can be spread in the floor of the mastoid cavity. Getting it now? Now we are seeing the tympanoplasty also. So you elevate it further. थोड़ा से खड़ा होके करता हूँ मैं क्योंकि मेरे को थोड़ा So you are elevating the flap like this. मेरा फोन किसके पास है? आंचल के पास. हाँ, कोई इम्पोर्टेंट आए तो आंचल जवाब दे देना बच्चे. Yeah, I am elevating this flap. Elevating, I have reached to the sulcus annulus there. Take the pick. After canal down, we can start with the dissection. The temporal bone people can start with the dissection, and skull base can stay back, and I'll keep on demonstrating the skull base. This is what to save the time. So you guys do the job. All 6 should be well prepared stations. You want to see the canal down? Okay. Okay. So give me a pick. Reach. The very important tip is do not elevate the flap from one place. Elevate the flap from all around so that tenting does not happen and it does not tear. Elevate it all around. Like this. And go inside. Can you see some impression of? Okay. So I'll go a bit medially. and ये पतली दे दो.
Sir,
Section. Yeah.
before canal wall down, can you show us the landmarks for lateral temporal bone resection?
Lateral temporal bone resection. Okay. So for lateral temporal bone resection, what you do is you go, keep on drilling till the base of the zygoma there. Drill lateral to this digastric ridge, got it? Up to here, and come anterior to it, and then posterior tympanotomy should be extended down, 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 and the tympanic bone should be drilled till floor and anteriorly. And from zygoma you are coming anteriorly, and then with maybe an osteotome or something like that, you make a cut and it comes out. Yeah, basically tympanic ring is like this. If it is deficit there at the revenous, the notch of revenous, but covered with the base of the zygoma and the squamous temporal bone, which is fusing with the base of the zygoma. So that makes the upper boundary. So you have to drill that squamous temporal bone till the base of the zygoma, cut it off the zygoma, and now drill the tympanic plate lateral to the facial and take it out. That is external. I'll show you it later, maybe in another case, or if you want to see that right now. Should show you that extracaustic canal. Okay, so lateral temporal resection I'll show you. Get me the bigger. Yeah. Now, body cutting bar. So you start drilling there and drill, and drill. Here the tegmen is very low anteriorly. You can make out that. It is not working. Give me another. Oh, I have broken the posterior now. You go like this. Off the dura, remove this bone. Go anteriorly. Go anteriorly further. Go anteriorly till the root of the zygoma I am going. Now do this job in actually what is happening, you have to concentrate on this now, getting it now, and then rotate हो गया. हाँ नहीं तो इसको इसलिए मैं बाहर किए हुए था तेरे को. जीरो 0.4 पे है ना. ऐसे रख. हाँ you see it, okay? So I will be going like this. इसको ऊपर कर ले. Here, because of this cadaveric position I am in, a bit troubled. you remove this lateral to the facial. हाँ मुझे जगह नहीं मिल रही है because of कोई बात नहीं ठीक है. So I am lateral to facial if you can make out. Lateral to facial going anteriorly along the tympanic bone. And this. And then some more. Make a cut off the zygoma. Take it off the zygoma. Soft tissue. Give me knife and forceps. Now see the soft tissue there. Cut this soft tissue along off the parotid. This cuff of the canal. Your condyle. Take it all along and you take this cuff, okay, and from here cut and take all the cuff. Look, the whole cuff you are taking out, drilling this bone further. Got it? So this is external canal. Excision you do. Some more tympanic bone is left there. If you drill this, what is this? Here. Your TM joint there. So you drill this more, you go along, drill this more, you will go to the jugular foramen and then there. I'll show you that now. So at first, show them the whole canal down. We'll show them.
Sir, you will go for superficial parotidectomy through the same incision?
Yes. Why should we do a superficial parotidectomy in the cases of CA middle ear or maybe external ear? Because there are some fissures in the anterior canal wall, fissures of Santorini, through which the lymphatics can traverse and go to the superficial parotid, which harbors the intraglandular nodes there. So they are the first Echelin nodes to your external caustic canal and middle ear. So the parotidectomy, superficial at least, should always be done along with that. And you should also remove the condyle of the mandible along to get the whole clearance. You have to ligate the superficial temporal there. But if you are planning for a flap, retract it anteriorly so that you preserve the superficial temporal, which is giving you branches to the which would be used for obliterating the cavity. Got it? So this is how you do. Now we'll do the canal wall down. Joint capsule we take. इसको आगे कर दे. Now remove the whole this thing. Even if you are doing a mastoid, remove this chunk of bone from there. Why? Because when you do a magnetoplasty, what happens? If you don't remove this lower chunk of bone. Through the myotoplasty, this bone would be like this. And your mastoid and the whole mastoid hides behind it, and it makes a reservoir for the wax and squamous epithelium to grow, to collect. So it should be flushing like this. Pre-sigmoid coming and flushing to the floor of the canal. The floor of the canal and floor of the antrum, the mastoid, should be at the similar level, or at least it should be a slanting one, so that drainage should be there. It is the principle of doing a good bone work there inferiorly. कोई बात नहीं, फट जाने दे. Okay, my gloves is gone. Here. Batch 1 started, good. Their assistants can go and see. They can help, and if the dissector is happy with your assistance, he or she can help, can give you some job doing on the bone. A good surgeon is always a good assistant. Without being a good assistant, you can never become a चलो सॉफ्ट टिश्यू करने तो बड़ा भी दे देंगे. बाद में पानी. आगे गुड. रख दे, एक तरफ रख दे. Can you make out the chorda preserved, the whole timpanic membrane, and the sulcus annulus is going. Can you make out the timpanic membrane? So this bone lateral to the facial should go. पानी. अरे किसी ने यहाँ से बंद कर दिया क्या? ये मत करो यार. Section बंद हो गई. हाँ चालू. Look, the facial is going so lateral now. And this is your digastric ridge, I told you. Can you make out? The facial is going towards the digastric ridge. Can you make out this facial? चालू हो गई? ये चालू नहीं. शशांक गया क्या? The other faculties, please help dissectors out. Okay? No. नहीं, किसी ने कुछ मंगाया नहीं क्या वहाँ से, कैंटीन से? रवि, कैंटीन से मंगवाओ, लोगों के लिए चाय बनवाओ, और ताकि डिसेक्शन जब तक सामान जुट रहा है उनको कुछ खिलाओ पिलाओ. कैंटीन से करवा दिया? वेरी गुड. Before scrubbing, you guys have something out there, because this will be 3-4 hours dissection. So you guys can have something to eat. Grab something fast. 5-10 minutes, 15 minutes, that's it. You can make out digastric ridge well. Facial is going. Pani. And this is what? What is bridge and what is ridge of the canal? What is bridge? What is ridge? A bridge requires pillars. What are those pillars? The anterior buttress and the posterior buttress. The posterior buttress is the bony ledge, which is anterior and lateral to the lateral semicircular canal. That is the posterior buttress. What is the anterior buttress? The supratubral bony hump, the anteriormost part of the canal, the outer atic wall. That is your anterior buttress. And the bone laterally is your bridge. You remove the bridge, you flush the buttresses, and you see the anterior atic and the whole facial down there. So this is how you go ahead, okay, in mastoid. So this is your anterior buttress. Got it? In live patients, before doing this, you should remove incus. Why? To prevent vibrations going in the labyrinth, to prevent tinnitus and hearing loss. Remove the incus, then do this job. Got it? And when you are doing an intact canal, remove the incus, cut the head of the malleus, so that you reach the anterior epitympanic sinus, which is a very prominent site for the residual cholesteroma. And how do you recognize that? By seeing for the cog there. Okay? The cog is a bony ledge which comes from the tegment tympani down there. Maybe completely, maybe partial.
Sir, excuse me. Sir?
Yeah.
Sir, during routine MRM, do we have to expose the facial nerve up to this level?
The canal should be intact, the fallopian canal. But what is the limit of your canal down? Very good question. Facial canal.
Facial canal.
The limit of your canal down is facial itself. Don't leave any bone over the facial except its bony canal. Otherwise, just enter to it, you will have disease in the sinus tympani if you don't remove that. The bone over it, bone enter to it, bone posterior to it might be having retrofacial cells harboring the disease. You have to remove that. Got it? हाँ वो lunch. Oh, sorry, which? Remove the tympanic membrane of its sulcus, okay? Got it? I'm not caring for the ossicle here, just for the showing. Otherwise, you should not be harsh while you are dealing that. Tympanic membrane out, and you see what? You see the Eustachian tube. You see the processus cochleariformis and the tensor tympani tendon. Can you make out? Give me a pic. So here your malleus was tendon, processus cochleariformis, and if you become vertical a bit like this, and now and it so you can appreciate the vascularity. It is not good for me. No. It's good for you guys. So this is your steppies. Can you make out? This is your steppies. Oh, some lag is there between my movement and there. Processes. And if you can make out the Jacobson's nerve there, can you make out? So when you do a cochlear route or any transcochlear, transotic approach, you should not go anterior to this Jacobson's nerve. If you are going anterior to Jacobson's nerve, you are छोटा section. It's very well seen there. Any concept left? Please. Last point. The landmark. I'll show you the landmark and then come. Give me a thing. So this is your, because of these handles and all, your round window. Can you make out? Round window. This stapes, tendon, pyramid, facial. Processes cochlear formis, tensor tympani. This is your Jacobson's nerve going. Can you make out? Jacobson's nerve along with the vessel. So this is the basal turn going like this, coming like this, going like this, going there. Apical turn there, there. So where would be your middle turn? Anterior to your, just anterior to your oval window, where this Jacobson's nerve is coming. Drop a line down this and you will have this here. I'll drill and show you. Give me the burr. This whole bulge of promontory is does not correspond with the whole cochlea. It only corresponds with the basal turn of cochlea. Got it? So if you drill here, नहीं इनकस को निकालना पड़ेगा. Can you see the middle turn there? Pick. Can you see that? I am in the middle turn now. Pick. And look, the perilymph is coming. Look, they are coinciding. The reflex there. Look, look, look. Okay? I'll show you the drill out now. Copy drill out. Now, get me a diamond drill. You see the middle turn? I have opened the middle turn for implantation. Or you can use double array implant. If some problem is there in the terminal part of your basal turn, you take double array implant. Put one in the middle turn, one in the basal turn. Job done. Or a reverse implantation if your this thing, can you see a cochleostomy there in the middle turn? If your basal turn has got fibrosis and ossification in the initial part, proximal part. So you come reverse. You put in middle turn and you come reverse. It will come like this. Got it? That is other way around. So I'll show you cochlear drill out now for ossificans. छोड़िए. Good. No, this is sufficient. No more. This is sufficient for implantation. Got it? So for cochlear drill out, drill along this. Drill along this. खूब water डालो. पानी, 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 पानी. Not like आज blue है पानी, पानी नहीं. Pani. And drill, and drill, drill. And you find a lumen, stop. You find a lumen, stop. You don't find, drill some more for implantation, okay? But don't go medially. Your neuroepithelium is medially placed. Scarpas are on the medially. And laterally is stria vascularis. I'll show you. Look, from here even the lateral canal will there because the whole labyrinth is interconnected. Smaller section. If you see, that is modiolus. Can you see something there? Look, arrangement of cells there. Can you make out a bit? I'll show you that. I'll show you by doing it and then okay. With this, I'll do now. Focus there? Yes. And for me, myself. A bit lateral for me. Oh. And for you, I think this is. So if you can you make out this linear shadow there of the modiolus spiral? The spiral lamina is coming, and if you take it a bit lateral, give me a pic, and you will see the laterally, this should have been there, some blood vessels. Okay, this is basal turn I have explored. Now we'll explore the middle turn. ये बार बार चेंज कर लेता है ना. Sufficient. Okay. हाँ मेरे को थोड़ा सा तो हाँ उनको वहाँ दिख रहा है. ओके कैन यू सी. हाँ करो. क्या करना पड़ेगा. अच्छा ओके. सो दिस इज मिडल टर्न. गो अहेड. पानी डालो एकदम से. Can you make out the middle turn is going like this? Okay? So this is how the cochlea is oriented. Like this. It is oriented in this canal, in this ear. This is round window, basal turn, middle turn, apical turn, anterior to the processus cochleariform is deep to the facial nerve. Got it? Look, this is oriented like this, lateral canal this, facial like this, facial like this. Okay? Then facial becomes like this in the antral acoustic canal. So this is the labyrinthine portion. Got it? Now we'll do the labyrinthectomy part complete and come on antral acoustic canal.
Sir, can you just outline the arrangement of osseous spiral lamina, how it is oriented?
Osseous spiral lamina. In this I'll show you. In-depth picture I'm not getting there. I don't know, my microscope has gone some. Can you see there? I'll drill it a bit. Come, come. Come, dal. But now. Can you make out something? Can you see the spiral lamina? Yes? Can you see? Beautifully it is seen there. Pick. This is your spiral lamina which is coming. And then here this is transscalar. I open it, and I'm, oh, ये बंद हो गया, मतलब. And I am in scala media there. Look here. This is scala media. And if I drill this, I'm taking it out so that for the ease of showing you guys. And this is sacule. Okay? Look, now remove this soft tissue. If I drill it up further, you will see scala vestibuli there. I'll show you that. Oh, हिल गया. Is it good? This was your oval window. One. Come. ये कर नहीं रहे. बस. वापस. Good. Can you make out? Can you make out this? This is your scala vestibuli. I am going in. This is your scala vestibuli. Got it? Scala vestibuli. ये टिम्पनाई है जो इसको कनेक्ट. This is the arrangement. Pick. And you see modulus is coming in picture, the nerve fibers. Can you make out the nerve fibers there? Look. Look the nerve fibers of cochlear nerve. And this is your scala. So this is how you do it. Now we'll do the internal acoustic canal exploration. The troughs, bone, body. Getting it there properly? Okay. Okay, so you see the subarcade artery there, you see the खोलो उसको, खोलो कोई बात नहीं. So this is how you drill मेरे घोंस मत देना. क्यों सक्शन नहीं है क्या? अच्छा मैं देता हूँ. जा उसमें नाम लिख देना किसका सेक्शन कौन सा है, मिक्स मत करना. हियर इसमें इधर से ले ले. और कुछ मत निकालना फिर. अभी बरबर थोड़ी चाहिए, ड्रिल थोड़ी चाहिए. रुमाल गिर तो नहीं रहा. Okay. So what at first I'm showing, before I am showing you how to make this facial bridge. Jugular bulb appearing, if you can make out from anterior also. Anterior to facial. Keep on drilling and you can make it vertical like this to see the things. इसको उधर ले जाओगे थोड़ा सा. हाँ, retract. हाँ, just to show them. Some more hypotympanic cell exploration. Come. And jugular bulb is appearing. Can you see the jugular bulb there now? So, anteromedial to the facial now. Nothing, no structure there. Safe. Then posteromedial, and you have made the facial bridge. Making the facial bridge, intact facial bridge technique. Now do further labyrinthectomy. Now what structure is appearing there, here? If I open this, what is this? What is this? Cochlear aqueduct. You have to open it. I'll show you that. Look. You have to open the cochlear aqueduct so that the pressure decreases in the internal acoustic canal when you open that for any acoustic neuroma or other tumor surgery, or even decompression, or even vestibular nerve section. You have to open it. Okay, khade karunga. So this makes your lower limit. You open it, look, and you look, it is coming, pouring in. And Mike's dot here, that makes your superior boundary. Now we'll drill. Drill. The bone of the bony ledge here, just medial to the second genu, you should keep intact, because facial sometimes comes very close here after taking a turn. So this bone should be kept intact, and the medial bone, you make a trough now. Trough down there. Utricle. Can you make out the utricle? Funny, funny that. Can you make the utricle and a bit of neuroepithelium, of utricle? Can you make out this? So this is utricle. I have explored now. Further exploration. When you do a labyrinthectomy, you should remove this all neuroepithelium. Otherwise, patient will have what this will keep on sending information to the epithelium of utricle and saccule should be out. This is my superior trough I am working on. I am going inferiorly. This is inferior trough I am creating. This is superior trough I am creating for the canal. Give me the bigger burr. टोटल बार गिन ली थी बच्चों को कितनी दिए हैं? ओरिएंटेशन नहीं, पहले थोड़ा छोटी पर दो, वापस वही वाली. So this superior turf, the inferior turf we are making, huh? थोड़ा ज़्यादा पानी मत डाल. bit of dura injury is there, which I am not paying much attention. If it was light patient, I would not have done this. So before going up and down, try to see the dura of the canal. These are dura. Let me orient, okay? Now I'll make it a bit like this and sit, and then where you are going, okay? Again, up and down drilling should be done. Is it okay there? Thoda focus. Pani hai. Canal. मेरे मत पोक कर. Oh, sorry, this was the wrong step. This is IAC I am exploring. This bird should not have gone like this. ओके ना इसको थोड़ा घुमाना पड़ेगा उधर कर सकते हैं क्या Can you get a glimpse of something there? Do you get a glimpse of internal acoustic canal there? Okay. Now give me a smaller bar or maybe a diamond. छोटी diamond रखी है नहीं बड़ी diamond दे दो हाँ look बने I want a 270-degree exploration around it. I'm keeping it intact. पानी डाल वहाँ डाले यार वहाँ आ ही नहीं रहा है हाँ डाल 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 So I have gone far anterior to the canal now. Okay? Here also, I'll go further. Now I'm ready to open the dura there. Can you make out the dura? Well, dental acoustic canal. Give me a smaller one. Yeah. Give me a pick or a sickle knife. हाँ चेंज कर दे You have to be very meticulous. When you are opening the dura, remove these bony pieces from all around. And now I can open this dura. And you find CSF is coming. And you find the neurovascular bundle there. Can you make out the neurovascular bundle? CSF pouring in. So what nerves I am seeing right now? Face on, ekdam, samne. What is this? There is a gap. Can you make out this gap? And this is a superior vestibular nerve. I cut, retract. Just after it, what is coming? What is this? Facial nerve. What is this? The inferior vestibular nerve. And the inferior vestibular nerve going up, the superior vestibular nerve, when it was making a superior ampullary nerve. Okay? So it was going and making a superior ampullary there. If I retract this, you will see this is your facial nerve and even the nervous intermediates there. Can you guys see this? Nervous intermediates? Beautifully? Okay. So if I cut this, and you will be seeing the, look, I have retracted this also. And you are seeing the cochlear nerve there. This I have separated. This was basically the, look, the cochlear nerve. Can you make out? Superior vestibular, inferior vestibular, cochlear, facial, nervous intermediates, and a branch of the ICA, antero-inferior cerebral artery, branching like labyrinthine artery coming in. It might be ICA, it might be labyrinthine. When it arises directly, a labyrinthine artery. When it comes like ICA from there. Okay? So you got the whole thing there. Once, if I open it further. Now, a retro-labyrinthine approach for vestibular section. You had labyrinth there. Open the dura here. Open the dura here. When you open the dura here, go, open, and you see this supravestibular nerve there. And from here you could cut this. Got it? From this place you could cut this. And this is the place where you open by the retrosigmoid also. You come from this place, make a hole, go in, you are coming here. And without doing that craniotomy, transmastoid, retrolabyrinthine approach, you are doing a vestibular nerve section. So easy for us ENT surgeons. Got it? You don't have to open the cranium there, back there. Okay. So we'll see other Can you see this? I have taken this transverse crest now. Now, if you follow this facial now, I'm having a pain there in back. If you follow the facial from here, cure it. Oh, sorry, I've injured it somewhere. Here. But if you can follow it here, if you can follow it from the off the labyrinthine. Oh, look. Focus. We didn't do white balancing, na? Facial coming like this, and it is like this. So that was facial. If you follow that entirely, I'll show you the GSP. Is it okay? Okay? Perfect. Okay. No, it's okay. Pani. पानी डाल साथ के साथ वॉश और रुक जा you see that and there you see that I'll show you you follow this show you. Follow the facial, going, and you see this small nerve going there. Can you make out? This is your GSPN. Got it? From here, facial was coming like this. This. And this is your GSPN. Can you make out? This is your GSPN. Look, beautifully seen. Can you make out that? So that is GSPN. Now what we'll do is, we have done this, we are going to see other nerves. अरे सब लोग सुनो रुक जाते हैं थोड़ी देर विल हैव स्नैक्स फिर अपन इंफ्राटेम्परल फोसा ए कैरोटिड को फॉलो करेंगे जुगलर को एक्सप्लोर करेंगे ठीक है मीनवाइल ये लोग कर रहे हैं फिर आप लोग सब करते रहना शाम को इसको बंद कर दिया यू गाइज एंजॉयड और नॉट गॉट द कॉन्सेप्ट एवरीथिंग ओके चलो अभी दोबारा दिखाऊंगा फिर स्नैक्स लेते हैं थोड़ा सा ब्रेक 5 मिनट और फिर ये मेरी पॉकेट से निकालने, पता नहीं कहाँ गया, तू इसको फॉलो कर ले, जैसे मैं नर्व फॉलो कर रहा था तू वायर फॉलो कर। हेलो हाँ हेलो आ रही है आवाज? ठीक है। हेलो आ रही है आवाज? ठीक है। मास्क, ग्लव्स, when the cancer is involving the middle ear, then you can't just do lateral temporal bone resection. Then you have to do a subtotal temporal resection. What does that include? The whole zygoma, the whole parotid, along with the styloid apparatus pura, the condyle of mandible. You have to do a labyrinthectomy, the cochlear drill out, the whole cochlear drill out. Facial, you can save transposing it posteriorly, but in almost half of the cases you can't save that, because if the disease is there, it would have involved that. That's why sometimes you can save that by drilling and transposing it anteriorly and taking out the whole bone till the Petrous apex. But you know, that is a very morbid surgery in which you have to take out the all squamous part of the bone, the mastoid part, the canal, the styloid, anterior zygoma, up there, up to the superior temporal line. Everything has to be taken out. And up to the Petrous apex. So that is very morbid surgery. And you know, if you compare the CTRT along with the total temporal resection, the results are equivocal. Although the results are not good by both the things as well, both the modalities. The maximum survival rate reported was 25%, 5-year survival, total temporal resection, because the disease. So these are very dangerous tumors. So we have done we did 2 temporal dissections, total temporal dissection in our department over last 18 years. Then we did not do that. We have done a good number of subtotal and fairly large number of lateral temporal resection. Don't confuse with subtotal temporal bone resection with subtotal petrosectomy. Subtotal petrosectomy does not require drill out, but subtotal temporal resection requires that. Okay? So subtotal temporal resection you are doing for malignancy, and subtotal petrosectomy you are doing for chronically discharging ear. Dead, non-functional, chronically discharging ear, you can do it. Or cochlear implantation in discharging ear with CSOM. You have to do a subtotal temporal resection, subtotal petrosectomy, implantation and cul-de-sac closure. That should be done. Dr. Sampath and Dr. Satish Jain, they are proponents for the subtotal petrosectomy with cochlear implant in any discharging ear. A few people, they just do a canal down and do it, but your implant is just like hanging in the cavity. So that is not good. If you close it properly well, then it is gonna have some help. Yeah. So now what? We'll remove this bone, we'll remove the facial, we'll go in the jugular foramen now. Okay? Bada. Yeah. Oh no, give me cutting bar. A big cutting. Yes. Anything else left? हाँ डॉक्टर लूथरा उसके अलावा और भी कुछ दिखाना है तो अभी what we are doing is we are doing some drill out of this hypotympanic bone, explore the sigmoid sinus, open it, see the inferior petrosal sinus openings there, and medial to it all the cranial nerves till the neck. Okay. One. You have to be very cautious here now because you have already opened the cochlea, drilled the cochlea. While removing this bone, medial to the Eustachian tube in the medial wall, if you drill this bone, this is the jugular bulb, you see. Over here, if you do some drilling job, enter to cochlea in the medial wall of Eustachian tube and protympanum. Some more cochlea gone. This is a Eustachian tube. So what is coming in view? Can you make out something is coming? Can you make out this bulge of carotid now? This is the internal carotid, vertical petrous part going there. So this is jugular bulb explored. You see the whole jugular bulb. Look the relation of cochlea. Relation of cochlea to the carotid. Give me a smaller bar. Yeah. See the carotid there. इसको थोड़ा यूं करो and you orient yourself. Okay, this is the carotid there. So this is carotid, vertical. This is your jugular bulb. We'll explore it further. We'll remove this mastoid tip, cut this muscle, see the neck vessels and correlate them with these vessels. बड़ा नाइफ और इससे इसको हटा दूँ सॉफ्ट टिश्यू forceps. Okay. This is a mastoid tip. Okay, I have removed this mastoid tip now. Even in chronic mastoiditis, chronic otitis media where you are doing canal down, you should sometimes, if it is very deep mastoid tip area where a lot of air cells are there, remove the mastoid tip. How does it help? You remove the tip cells, and after removing this mastoid tip, your sternocleidomastoid muscle falls in the cavity and it contracts the cavity. Got it? Our teacher, Dr. Sunil Samdani sir, does it a lot. So this mastoid tip removed. And this is your sternocleidomastoid. I'll go enter to it. And this is your parotid. So this is your parotid. This. Your parotid there. This is your sternocleidomastoid. And deep to it, this comes your digastric. Can you make out? This is your digastric. Okay, okay. So this is your digastric which was inserting there in the digastric ridge there. Mastoid tip removed. This is digastric. This is sternocleidomastoid. If you dissect between them, this is your level 2. Got it? This is your level 2. So give me seizures. I have opened the neck now. Look, these vessels are known as veins of Chalker. Dr. Devendra Chalker is there as a consultant there in Tata. He has given these veins of Chalker. If you see this, these are landmark for spinal accessory, yes. So these veins, I open this gauze and you see this nerve. You see this nerve. This nerve, can you make out? This is spinal accessory nerve. Got it? In level 2. It divides level 2 in level 2A, which is anterior inferior to it, level 2B, which is posterior superior to it. When you go medial to it, open this fibrofatty lymphatic tissue, you will see the jugular bulb there. इसको थोड़ा और काटें.
One more thing, so like facial nerve is transected, then we have to take the spinal access, that retroauricular we can harvest.
You can harvest, yes.
From where this
I'll show you. So this is mandible coming in view. Can you make out mandible there? I'll show you. Now, this is angle of mandible. You have seen this accessory. How to know the position of accessory? Three things. One, Erb's point. Erbs, E-R-B, apostrophes. Second, these veins of Choker. And third, what I am feeling is transverse process of C2. Got it? The transverse process of C2, if you feel, this is there, over which this nerve traverses. Got it? These are three things which can tell you where your nerve is located. If I go along the nerve, this is digastric, we are retracting the digastric, cutting it, retracting it further, going behind the mandible, and then opening a bit there, and what you see is IJV. Can you see this IJV? And then you see IJV. Can you make out IJV? So this is your IJV. Can you make out IJV? Okay. Look. So this is IJV. And anterior to IJV is what? In the neck is your carotid, would be there. So this is your vagus, and here would be your carotid somewhere. Can you make out carotid there now? Can you see carotid there? Okay. So this is your carotid, this is your vagus, this is your IJV. Got it? We follow this IJV up, and you see that. What is this artery coming in view? What is this artery which is coming in view? It's the occipital artery. Got it? Look, this. I'll cut it. Don't worry, I'll cut it. I'll cut this tissue. I'll cut the parotid to show you the things. This is parotid I'm cutting, okay? I'll show you parotid in head neck workshop, don't worry. Someday. Okay, so you can see the occipital is going there. Look, Pragya, I told na, when you are there in the level 2, your occipital is there, superior. So if your over enthusiastic surgeon or your assistant retracts the digastric posterior belly much, your occipital would be coming and you can injure it. And this occipital artery is gonna supply your post-auricular flap. Come, look. This is coming, look. This is coming and looping, look. Can you make out the whole occipital there? This is your occipital artery. Got it? And, yeah. And that is your IJV going up there. This is your IJV, na? So this IJV is going, look. The IJV is going up there. Yeah, this is your IJV going, okay? And now I'll drill this part, the tympanic bone further. Tympanic bone is left, na? Section. So you drill this tympanic bone further. This. बड़ा दे दूँ ना यार. This is what I'm drilling the base of the styloid process. So this is basically the styloid apparatus. Badi bar. This section. I have to drill this bone to explore the jugular foramen. Can you make out? It is continuation. In continuation, it is going like your IJB down there. Look. And if I open this, medial to is would be, this is your jugular wedge and there is your jugular tubercle. I am drilling. Got it? The jugular tubercle. When you drill, you have to be careful about one vein known as.
Sir, please centralize.
Sure. So this is jugular tubercle I am drilling. Just, oh, sorry. So jugular tubercle I have drilled. Just poshu medial to jugular tubercle, if I drill some more, you will get one vein that is known as condylar emissary vein, which goes transversely there. So, can you make out? I have exposed this jugular. And this is in continuation with the jugular vein down there. I have cut that. Okay. So now, if I open this jugular, साफ कर दो. If I open jugular now, हटा थोड़ा सा. Okay, some bone is there. I'll remove.
Sir, while
Open the jugular bulb. Remove this bone further. Give me. Remove this bone further. Now I have opened the jugular bulb. After doing extraluminal obstruction there, obliteration there, what I'll do is, before opening there, I'll go extraluminally there and I'll put in Sergi cells or bone wax or, sorry, over here. I'll obliterate this jugular so that no bleeding should be there. And I ligate the IJV down there, but still bleeding would be there. From where? Inferior petrosal sinuses. Got it? So suppose I have obliterated it. Now I am opening the jugular bulb. Look. And now, forceps. Okay, jugular, this sigmoid sinus going, making the jugular bulb, and jugular bulb going down and making IJV. Okay, now it is central focus there. So this is lateral wall jugular you have opened after obliterating it and ligating the IJV down there. What you see there, I'll show you. Can you see these openings there? Suction. Small openings. Can you appreciate these openings? Look. Can you appreciate these openings? There? Can you appreciate? Those openings, when you see that, they are inferior petrosal sinuses. Look, these openings, they are inferior petrosal sinuses opening just below the jugular bulb. Got it? And if you remove this wall a bit, what you will be seeing? The jugular foramen is open there now. And you start seeing the cranial nerves. Can you make out these openings? Inferior petrosal sinus openings there. I'll drill it a bit. Medial to it, you will find 9th, 10th, 11th, 12th going. Not 12th, 9th, 10th, 11th. 12th goes through the separate canal, hypoglossal canal. I am removing the jugular tubercle a bit more. And when you do this, look, some more. Here also. And when you open this, I'll show you. Give me a repositor or something like that. Okay. Yeah. Carotid is entirely there, and look what comes. ऐसे कर. What are these? Okay? What is the anterior part of jugular foramen? Nervosum, the posterior venosum. Got it? But the nerves are there in venosum, not nervosum. Got it? So it is there in the posterior part. And if you see them, you will start seeing the nerves there. If I open it further, you will start seeing the nerves. Sickle. In the medial wall. Can you make out the nerves there? Now? Okay? The 11th was there. We have broken that and dissection. It was coming like this. 10th going like this. 9th going like this. Got it? 9th, 10th. If you follow 10th from down there, if you follow this, this is your 10th nerve. This is your occipital. I am cutting its branches. So occipital I am taking apart. Now follow your 10th nerve. This is jugular going in there. Here it was. This is 10th nerve coming. Take it further. Can you follow? Can you follow? Look, this, coming here. Give me seizures. I'll open this. And this jugular, there goes your 10th nerve. There goes your 12th nerve, if you can see, going horizontally, anteriorly. Got it? So this was 10th. So this is whole jugular foramen you open. Got an idea? If you follow the carotid now, leave everything now. We'll go and follow the carotid anteriorly. So you have already done infratemporal fossa type A. In type B, when it is the horizontal carotid or second geno is first geno, horizontal carotid is involved with type B. Then if it turns out to be just inferior to foramen petrosum or that paraclival part is also involved, you go up to the nasopharynx and sphenoid sinus and drill everything, but you have to sacrifice the mandibular nerve in between. That is type C there. Type D is preauricular, transdiagomatic approach for paraorbital and nasopharyngeal parasphenoidal lesions. That is type D, you go anteriorly. Okay? So if you go further with the carotid, thank you. You keep on drilling the bone which is lateral to the. Hi, oh, thank you. थैंक यू सो मच. थैंक यू मैम. अभी बस 2 बजे करते हैं मैम. प्रिंसिपल साहब को बुलवा लूँगा फिर मैं उधर कुछ खाने को भिजवाऊँ. कोफ्ता समोसा एंड ऑल. वन ऑफ द सीताराम उनके पास मैं भिजवा दूँ. सीताराम 10-15 कोफ्ते समोसे मंगवा. हाँ ठीक है मैम. ठीक है तुम भिजवाओ है ना, उधर भिजवा दो. So you be lateral to it, remove this bone. Condyle we should have removed, but it's okay, I'll not remove that. I am going medial to condyle, it should have been removed. I am going along the carotid. We have to remove it. Huh? We have to remove the रुक जा, इससे एक बार थोड़ा सा और ड्रिल बनता है. जायगोमा को थोड़ा और कर देते हैं. So I am drilling जायगोमा some more. ठीक है, अब इसको वो दो, नाइफ दो, नाइफ, नाइफ एंड फोर्सेप्स. Actually, in cadaver, it has got fixed. Otherwise, in live patient, you can very well dissect all these things. Can you make out this? So this is your condyle. This is your condyle, okay? We have to cut the condyle. Look, can you make out the condyle there? We have to cut this condyle. Separable, huh? Separable है. Look, look, it is coming now. You do it. You do it. Young hands. I'll cut. I'll cut attachments. This is sphenomandibular ligament I am cutting. The anterior sphenomandibular ligament. Okay? Okay. So the condyle has come. Okay? Can you make out? Now, we'll go along the carotid for type B. Remove this fat also. Oh, some cramp. Cramp. Oh, section change kar do bachcha. And now you go along the carotid. You have to follow the carotid and take the tumor along. Go till the limit and then take out with the tissue. लगा दो. सब लोग और बाकी लोग देखते रहे उधर बच्चों को. This bone. There it is taking a turn. Can you make out? Taking a turn there. कर सकते हैं. ये ऐसे जाना पड़ेगा और एंड इसको यू. Yes. It is seen there. Visible. Okay. You remove this bone lateral to it. Remove. And follow this anteriorly. Remove this as well. What is this? Oh, इसको निकालना. पकड़ो. Part of the bone there. You remove this part of the bone. Remove. with forceps you remove it. Scissors ले ले, नहीं आ रहा हो तो मुझे तो scissors पकड़ो, क्योंकि तेरे को दिख नहीं रहा होगा ना. नाइफ मुझे तेरे को दिख नहीं रहा होगा. So this is basically the capsule. Can you make out? This is the cartilaginous part and the capsule, articular surface. It was. There you see the ITF. You are in the ITF now. Infratemporal fossa, okay? Just after mandible condyle gone, you are in ITF. This is mandibular facet. Can you make out this? Okay? So you remove this now. You keep on drilling anteriorly and
Sir, at this point, can we also see the masseteric nerve?
yeah, masseter is yeah, you can see. Look this part. Here it should be lateral to it, a bit lateral. Masseter is lateral, na?
Yes, sir.
So lateral to it is masseter. These are fibers of masseter there, somewhere here. But this is lateral pterygoid which is coming in view. Okay?
And just between this masseter and lateral pterygoid, we'll have masseteric nerve.
Masseteric nerve, na?
For
Which you find for facial reanimation.
yes, sir.
Yes. But in this cadaver it would be, yeah. Can you make out something there? Looks like that. There. Looks like the middle meningeal artery going up there.
Oh.
Can you make out? And then it turns and in relation to GSPN goes up there and intracranially it pierces. You go further anteriorly, further drilling. And there you are in ITF. Go further, and from here, if you follow this carotid there, खुल गया. चेंज खोल दोगे बच्चे, इसके अंदर से खोल दिया अगर सिरिंज से यूं. What is the time? We have to stop at 1. 12:45. 15 minutes more, we are done. Because we have to give them some time for these ward boys to arrange bodies for us, for you all. Half an hour more and your time is up, I think. कितने बजे शुरू किया था? 10 बजे. चलो करो, सवा बजे तक करो, अराउंड 1:30 बजे तक कर लो, कोई बात नहीं, ठीक है. 1:30 बजे तक कर लो, तब तक हम लोग खा चुके होंगे. You go along the carotid like this. Look, carotid is going and keep on going there. Look. And then what will come? Foramen petrosum would come. You are close to the brain there, everywhere. This is your carotid going. I have opened it somewhere, looks like. If you keep following the carotid, you will go to sphenoid and nasopharynx. At first paraclival, I am following the carotid. Look, give me a elevator. So this is what your genu is, okay? Getting it? This is your genu. And I remove this bone, go along, remove, and just enter to it is what? Eustachian tube. I am retracting. Let me drill this. Can you follow the carotid there? Petrous carotid, horizontal petrous, I am following. Yes. Now you will encounter the nerve. Because where have you reached? Just inferior to the macles. So what nerve you are encountering there is your mandibular nerve. There, you can see that. Can you make out this nerve? This is your mandibular nerve which you have to cut to gain further access. Look, I have cut for type C. Now type B is finished here. Horizontal exploration done. Type C, you further cut mandibular nerve, drill and go medial to it, and you will be there in the paraclival part. You can go by the combined approach. Someone is putting in an endoscope through the sphenoid and see the clivus. When you are reaching from there to there, you can drill clivus a bit. Give me the diamond now. So I have cut the mandibular nerve. Almost reaching to foramen petrosum there. Section and bar भी मुझे मोटा diamond दे दो. हाँ diamond. Cut end of the mandibular nerve, can you make out? Okay, so this carotid is going. इसको पूरा खोल के डालना होता है ना? ये अच्छी bar नहीं है. This bar is not good. This bar is not good. दे दो. ये छोटी नहीं चाहिए, थोड़ी सी बड़ी चाहिए. the bone lateral to it. Move this. You are safe, don't worry. Go entirely along the carotid. Open this. Look, you are going along. And that makes your, just up to the foramen petrosum if you are going, this is the cancellous bone which has come now. I can make out. Here you have to stop for type C. You are done. If you want to see the nasopharynx, we'll open it. Look. Just go along the carotid. That is the thing. All around carotid. Go along, go along, go along. You can see the carotid, how the carotid is going. Going. Go along, go along. And now if you enter here, seizures. There comes your intracranial part. Here it turns up, the second genu, just at the foramen petrosum. It doesn't traverse through petrosum. It goes like over it like this. And then it becomes intracranial there, I'm showing. No. Badi wal seizures though.
Sir, where will be the cavernous segment?
Cavernous will be more cranially placed. At first we are seeing the paraclavial carotid. Getting my point?
Yes, sir.
Here you are there in paraclavial carotid. Almost in sphenoid sinus.
Yes, sir.
Can you make out? I'm finding it very difficult, dura. I have to retract this dura. Then, look. What is that? That is your sphenoid sinus coming in view. There. Can you make out?
Yes,
That
sir.
is. Or I'll show you that. You keep it pressed there. If I could, but we can't make it. उधर से पुश करना, मैं सक्शन को पुश को अंदर धीरे along the floor जाओ, थोड़ा ऊपर जाओ, थोड़ा सा ऊपर जाओ. Look, this is your okay. Push. Obstacle आ रहा है. Should I do it? Yes. Yeah.
Sir, we should combine
Yeah.
an
Can you
endoscope.
make out such a beautiful approach it is? Dala?
Sir, we should combine an endoscope.
Yeah, we should combine. Endoscope we don't have. Yes, now you are there, in there. Okay, so you went along the floor, right? Then. So I think this ends my dissection there. Okay? Thank you. सब चीज़ों को संभाल लो अच्छे से ना. इसको इनको साफ करना पड़ेगा।
अभी करता हूँ सर। वो कौन है अपने
हाँ, ये अभी ऐसे
मार्क्स कौन देगा?
मैं दूंगा। हाँ, अब मैं देखूंगा किसने क्या किया।
सर पूरा अंदर से है।
उधर जो है जब हम जुगुलर फोरामेन के पास ड्रिल करना शुरू करते हैं सर वहाँ पे फेशियल के ट्रंक को कैसे बचाएं?
फेशियल ट्रंक ऊपर है, लेटरल है, तो फेशियल ट्रांसपोजिशन कर रखा है आप।
हाँ ट्रांसपोजिशन कर रखना है सर बट
बस।
वहाँ वापस डायगैस्ट्रिक के ऊपर जो आती है
नहीं आएगी। जब फेशियल ट्रांसपोजिशन तो फेशियल को आपके पैरोटिड तक एक्सप्लोर करके मेस्टोइड टिप को हटा दिया और फेशियल को आगे ले गए पूरा।
सारी चीज़ें अलग वो सर आगे वो टेकअप फर्दर नाउ हेलो 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 सेक्शन मेरे को गलत बता रहा है
टिप के साथ ही और टिम्बरिंग बोन जब ली, टिम्बरिंग बोन से तो जुड़ा हुआ है नीचे, तो हट गया। उसको हटाना पड़ेगा, उसको काटना पड़ेगा, उसके अटैचमेंट को 3 मसल्स होती है, तीनों काटनी पड़ेगी। स्टाइलो ग्लॉसस, स्टाइलो आई एंड स्टाइलो पेरिंजियस, तीनों।
रख दो।
ये सबको ना लेके जाएंगे, वापस धुलेंगे और लेके जाएंगे। उधर से आऊँगा। कैमरा फोकस कर रहे हो या good afternoon guys. So we have arranged temporal bone dissection, hands-on temporal bone dissection as well as lateral skull base dissection course at SMS Medical College Jaipur. This is the first comprehensive dissection course. We have already done a few courses like they were not fully planned. So now we have started with ENT Gurukul. So in association with Department of ENT SMS Medical College, AOI State Branch of Rajasthan, I am Secretary to AOI State Branch, and our ENT Gurukul we have started with the purpose of training residents and young consultants about the right from basics to the advanced and what new is going on in the field of ENT. So this is the third Gurukul we have done. The first one was cochlear implant evolution and planning. The second was a PG inter-college PG quiz. Now this was a comprehensive workshop. We have 14 dissectors in temporal bone and 10, we had 10 and 10, 10 for skull base, 10 for temporal bone, but more and more people were coming. We had to stop at 14 because we can't afford any more than that in, with our paraphernalia, with our infrastructure we do have. So I hope you guys would have enjoyed that. With that, thank you so much for watching. Please message on the YouTube or maybe on my phone. You can get it from the net, from Facebook, or even on Facebook you can ask any question, any concern, any query, any comment, and please contradict any of my step if I was wrong somewhere so that I can correct it for future. Thank you so much.